Neurosurgical Case Room. Am I audible?
Yes, ma'am.
Okay, so just a brief announcement. We have more or less finished the frontotemporal anatomy along with insula and the basal ganglia and the sylvian fissure. So we are in a very good position right now to do all the surgical approaches of this region at least. So we will be covering in the coming 2 weeks the surgical approaches for the temporal lobe, for the frontal lobe. It might include some sessions for the case-based discussions and some for purely approach-related sessions. So with this brief announcement, let's begin. We are going to do pterional craniotomy. This is considered the workhorse of neurosurgery. Almost every neurosurgical resident must have done a pterional craniotomy during their residency. It's not possible to do a neurosurgical residency and not do this. So I am sure you're going to find this session very, very easy in comparison with our usual sessions. Let's start. So we have already decided that this is the workhorse, right? Workhorse means this can be used for a lot of different reasons, for a lot of indications, and for a lot of structures, because it allows exposure simultaneously to the frontoparietal operculi, to the temporal opercula, along with the basal cisterns. If we go deep enough, it also allows us to split the sylvian fissure. It gives us access to the circle of Willis and the anterior circulation, especially. It gives us access to sella, especially if the lesion is unilateral. So sella and the paracellar regions, the cavernous sinus, and the upper clivus. There are a lot of indications. I'm sure you would be aware of them. So we are reviewing them briefly. The pterional craniotomy is a beautiful approach, especially for all the extraaxial tumors of the anterior cranial fossa and a lot of tumors from the middle cranial fossa as well. You can get them out with the help of a pterional craniotomy, or maybe using a modified version of pterional approach. For example, you can take out sphenoid wing meningiomas, tuberculum cell meningiomas, olfactory groove, if they are more towards one side, if there's asymmetrical growth in them, if there's a cavernous sinus lesion. For intraaxial tumors, we are aware that through pterional craniotomy, we can split the sylvian fissure, hence we can approach the insula. Since we can approach insula from here, intraaxially, we can also go deeper to the insula using the transsylvian transinsular approach, which is a topic for tomorrow's session, inshallah. So we are aware of all these extraaxial and intraaxial tumors, but pterional craniotomy is a workhorse in the neurovascular domain as well, because it provides beautiful access to the terminal portion of ICA, to the MCA bifurcation or trifurcation, whatever it is, to the ACOM artery complex. Part of the posterior circulation can also be accessed, especially if you can take out the posterior clinoid. It will give you access to some of the posterior circulation, like the basilar apex and the superior cerebellar artery. You can also reach the PCOM from here. So this is a versatile approach. Then again, if there are any AVMs in the perisylvian region, then that can be accessed via the pterional approach as well. Are we all on the same page, or am I going too fast?
Yes, ma'am.
Okay.
Dale,
So,
dale.
muted. Okay, let's proceed. So there are certain limitations. Obviously, if the lesion is bilateral, if it is more towards the midline, or if it has equal growth on both sides, like olfactory groove meningioma, for example, then you cannot approach it adequately from a unilateral side, and pterional is obviously a unilateral approach. So that is a pretty obvious limitation. The other limitation is there will be certain lesions in which the sphenoid wing may obstruct the deep view, especially the sellar region. and the part of the paracellar region if it is going on the opposite side. So for that region, you will need the orbitozygomatic approach. I'll give you an example. For example, this is my most favorite illustration, by the way. I keep drawing it. So this is the lesser sphenoid wing on both sides. We know this is planum sphenoidal. We know these are anterior clinoidal processes on both sides. So sella is going to be somewhere here, right? Let me change the color so that I can show you the lesion. If there is a lesion which is extending here, then you can approach it from a unilateral pterional craniotomy. If the extension is also towards the other side, then approaching the contralateral side is going to be really difficult. You will need significant amount of retraction, which is often not possible since a lot of critical neurovascular structures are in this region. So for these lesions, a better approach is orbitozygomatic, because instead of going through the sideline, orbitozygomatic approach is going to go like this, or sometimes like this. So that approach will be a lot more direct, and hence you will not need any form of retraction. Let's clear this.
Can you
There's a
also demonstrate the bicoronal approach to that sphenoid wing? As you said, that bicellular, and if the lesion is on both sides and we are doing it through bicoronal, so can you demonstrate it how we'll enter to that area as well?
I'm sorry, I did not get to your question. What do you mean by,
Mm,
can you repeat the question?
Okay, so my question is that as in the olfactory view meningioma, we preferred bicoronal approach, the SOTA incision. So can you also draw it here? So how, as you said, that OZ approach will be not from the sidelines, but a bit through the front, anteriorly. So can you also draw the bicoronal approach? How will that be as well?
Okay, Dr. Ahmad, I think you have missed our session on the olfactory groove meningioma and the the
Yes, ma'am,
bifurcal approach.
because of the
There
duties.
we have a complete session which includes all the surgical steps, the craniotomy, the incision, and everything. So if we end up going into that, A, it will be a repetition, and B, it will take the time away from the from the pterional. We won't be able to continue it. I'll
Okay,
leave a
ma'am.
link.
Yes,
Uh,
I'll watch those videos. If I have question, I'll then text you. Thank you, ma'am.
No. That's okay. That's completely okay. I'll leave the link again, and I'm sure it will help you because the bifrontal craniotomy has been completely explained there. Let me go back. So far we are clear on the limitations on the pterional craniotomy, right? There was one specific limitation that I have not written here: high riding basilar. If the basilar apex is high, you cannot approach it from the pterional craniotomy, because even if you end up taking the posterior clinoidal process, you will not be able to view this apex. So if there is anatomical variation, if there is a high riding basilar apex, then you cannot approach it from a pterional craniotomy. That will become a contraindication. Some other contraindications, which are common to any approach, whether it be pterional or anything else, if there is a surgical site infection already, if there is an infection in the region we are planning to operate, then that is a contraindication. Or sometimes a previous surgery has been done and it has resulted in significant amount of adhesions, etc. Then redo surgery is possible from that side, but it will be more problematic because all the anatomical planes will be destroyed. So moving on. Position is very straightforward, probably one of the easiest to make from the resident point of view. So the patient is supine and the head is rotated. The rotation depends on the pathology. It can be rotated from 30 to 60 degrees. If you are doing it for the ICA, you want to approach ICA or the carotid terminus, then the rotation is around 60 degrees. If it is for basilar, then it is around 30. For ACOM, I think it's 45 degrees. For the usual lesions that we do, like sphenoid wing meningiomas and etc., it varies around 45 degrees something. Neck is slightly extended. Why do we extend it? Because we want to utilize the gravity and we want to have the frontal lobes retract away naturally from the orbital roof so that we get some space in there. The highest point is really, really important, and especially if you are an exam candidate, this is frequently asked once they ask you to draw the craniotomy and etc. on the skull. You have to remember that for pterional craniotomy, the highest point is going to be malar eminence or the zygomatic bone. The goal is again same. You want to use gravity to do the retraction on your behalf so that you do not need fixed mechanical retractors. I'm going to show you a few images ahead. So you can see the position, the rotation of the head. It is slightly extended, slightly rotated around 30 degrees something. The ipsilateral shoulder can be elevated if you want to. Along with that, you can look at the placement of Mayfield pins. The paired pins go posteriorly around the mastoid region and on the occipital region. The single pin goes in the middle pupillary line. You will have to assume that this is running in the mid pupillary line. So it goes there. The incision is visible, but we are going to discuss incision very thoroughly, inshallah. You can see that it is a curved incision starting in front of the tragus, ending around the midline. There are certain variations. Let's look at them as well. So you can take a clearer look at how the pins are placed. For those who are not familiar with Mayfield head holder, I recognize that there are a lot of institutes which do not have the 3-pin head holder. You can look that this pin is placed around the mastoid region. This is mastoid, and this usually goes around the occipital area. This single pin, the unpaired pin, goes interiorly, and it comes in the mid-pupillary line. The incision that is shown here is one variation. There is another one, but let's discuss this here. We have tragus here, and along with the tragus, we know 1 centimeter anterior to the tragus, we have a branch of the facial nerve. We also have the superficial temporal artery, which is running around this region. So what we do is, there are 2 different approaches, not too different, as in there are authors which say begin under the 1 centimeter, but then there are authors which emphasize heavily on a very good cosmetic outcome. They say to begin within 45 mm. Specifically, because this is where the incision for facelift is given. So this is usually a natural skin fold. If you begin within the 45 mm, very anterior to tragus, the incision is going to be very minimal, and the effect is a lot more cosmetic. But as long as you are within 1 centimeter, you are good to go. Then it goes up, curves around the hair. You have to stay behind the hairline for cosmetic reasons, which are very obvious. And you have 2 options now. Assuming, let's say this is the midline. One option is you can either go and cross the midline slightly, and on the other side, and this incision is also good to go. The other variation that I have used in my own clinical practice very frequently, way more than this one, is the one which follows the curve of the widow's peak. I'm going to draw it here. So what we do is, we take this incision, we come on the midline, we follow the natural widow's peak, and go on the other side. So what this incision does is, once you retract it, it will give you a lot more exposure than the incision with the yellow line. So it depends on your goal. If your lesion is small, you do not need a very big flap and you do not need a big incision, then the yellow incision is going to be just fine. The purple incision is a very good choice when you want more superior access and slightly more posterior access as well, because once you retract it, it's going to go a lot more posteriorly. So you can undermine this entire portion here, which is usually not possible. in the yellow incision, once you retract the flap down, you won't be able to retract this portion here. Am I making sense? Is it clear?
Yes, ma'am.
Obviously, it's a
Yes,
lot
yes.
easier to tell this on the live patient rather than on the static images, but let's see. Let's hope we can get that as well soon. So we have discussed the position. The rotation is from 30 to 60 degrees towards the opposite side, and the angle would depend on the pathology. We have discussed that. Extension we have already discussed. Highest point we have discussed. We know that we need to keep the head elevated above the level of the heart, approximately 15 to 13 degrees, so that we facilitate the venous drainage and reduce ICP. And the principle, which is for all surgeries, goes here as well. Pad all the pressure points, take care of the eye, take care of the orbit, so that there is no unwanted consequences post-operatively. This is the example of, it's a very morbid looking cadaver, by the way. And this is an example of the incision that we discussed in the yellow. And you can see that this text says you begin 1 centimeter anterior to the tragus, extend cephalad to the hairline, ending at the widow's peak. This is the incision which is in Greenberg and which we have followed personally during our training and after the training. And you can see the facial nerve around there. You can see the superior temporal line is not marked, the superior temporal artery, but it's also somewhere around here as well. And you see this beautiful peak. So this 35 to 40 mm anterior to tragus is the facelift technique. If you're very concerned, for example, if you have a female patient, she's very concerned with the scar, then you can offer her this incision. It will leave a better scar in comparison, and the nerve protection is added. You know that already. The goal is to preserve the superficial temporal artery, especially if you are planning to do a bypass surgery. That goes without saying. But even then, if you don't want to have a lot of bleeding in the surgical field, and if you want to ensure that the flap will not have a necrosis, you have to preserve the superficial temporal artery. I will admit, though, that there have been times where I have inadvertently sacrificed this artery. It has not led to a lot of consequences in my patients, but if you can save it, save it. The incision is done in short segments, and because you want to have very good hemostasis, and you secure any bleeding vessel with a bipolar, or you can use artery forceps, the hemostatic forceps, or Rene clips. Only cut through the incision, through the skin. This is a common mistake that I see junior residents making. My surgical mentor was particularly strict with this. Dr. Etizaz, he was very strict with this when I was beginning the surgeries. Only cut through the skin, never incise the temporalis fascia at this point. It will result in a better dissection. I have seen people doing it. It's not a good dissection technique. So avoid it. Stick to the skin. Save the fascia so that you can decide what you want to do with the temporalis later on. So in this image, they have already taken away the flap and retracted it with the help of these pins. When we are doing surgery, we have two options here. Let me draw. We have two options. So one option is you can, in fact, let's discuss one thing before we discuss the periosteal lifting. There is a general principle, regardless of whatever craniotomy you are doing. Let's go back. So there's a general principle. The general principle is, I'm sure you are all aware of it. It's pretty basic, but let's do it here. Assuming that this is going to be your craniotomy. Your craniotomy margins should always be under your skin incision margins. Your skin margins and your craniotomy margins should never overlap. It should never go like this. an ideal approach is when your incision is going like this and your craniotomy is going under it, or let's say it's somewhere here. I am not concerned with the particular craniotomy that you're making here. What I am concerned with is your burrs should always be in a different line than the skin incision. Why? Because for the very obvious reason, if you don't want post-operative infection, especially osteomyelitis, if you don't, even if in the worst case scenario, if your patient ends up developing skin infection, it is not going to go to the compromised bone quickly. In comparison with this, say, if your craniotomy is here, right under the skin incision, your burrs are in line with your skin incision, then you can land your patient in problem if they end up developing the skin infection. So this is a basic principle. I'm not sure how many of you were aware of it, but always remember this. Let's move to the next image. So we are back here. Once we are done with the skin flap, the goal is to go through the myofascial dissection. We want to take the periosteum away, and we also want to take the temporalis muscle away. There are different methods of dissection here, and every surgeon has their own preference. The method that is given here has a very good cosmetic outcome. This is not something that I have done in a lot of cases, though. I'll tell you the other option. I'm sure you are aware of it already. So assuming there is periosteum intact here, so what you do is you mark the incision with the unipolar right on the periosteum. You elevate the edge with the help of a forceps, and then you start your subperiosteal dissection with the help of periosteal elevator, Penfield, whatever you want to call it. So till the superior temporal line, this here is the superior temporal line, where the temporalis muscle and fascia is getting attached to the squamous part of the temporal bone. So this is superior temporal line. Till here, periosteum is not going to give you a very hard time. It's going to slide right off beautifully. If you're not aggressive with it, it will come in all one piece. Now you have an option. What you can do is, you can make an incision here and retract the periosteum anteriorly. That is one option. What I personally do is I continue the subperiosteal dissection even below the superior temporal line here, and I keep picking it up using unipolar cautery on very low voltage, and we separate the periosteum from the skull very gently. You don't have to burn it. You have to be very gentle with it, and you take it completely away right down till here. So by the end of your dissection, you will end up with a big flap, which will have periosteum and the temporalis fascia. Now, there is a problem with it, though. I have done this technique as well in a few cases. I find it more cumbersome, but it results in a better cosmetic outcome. What you do here is you take the, assuming that we have taken this periosteal flap and we have retracted it over on this side. The other option is, let me use a different color. You can give a separate incision over here, just underneath the superior temporal line, leaving a cuff of the fascia or the muscle. And you give an incision here, then you continue your subperiosteal dissection for the temporalis muscle so that you can retract it inferiorly. What this is going to do is, once you are done with your craniotomy and everything, and you're closing, you're putting your bone flap back. Once you put the bone flap back, this cuff is going to be there, this purple cuff. And you can bring back the temporalis fascia over it and suture it right here. So
Madam,
this,
can you please raise your voice or please hold the mic near to your mouth? The
I'm very
sound is
close
very
to
low,
my
madam.
mic.
Please. Sorry.
Am I audible to everyone else, or is it just Dr. Abid?
You're audible, ma'am.
Okay, Dr. Abid, I think it's a problem on your end because I am literally in the face of my mic. Let's See, I'll try to talk louder. So what we do is we flip this temporalis muscle inferiorly. Once we take it back and we suture it here, this is going to result in less retraction post-operatively. Retraction as in the fibrosis and the retraction that a muscle goes through after the surgery, and a much better cosmetic outcome. Patient will not have the temporalis atrophy that sometimes patients can have following a craniotomy in this region. So the cosmetic outcome is going to be a lot better. I wanted to explain both the options. Let's see this one. So you can see they have left a cuff here on the superior temporal line. The fascia is there. A slight cuff of muscle is also left. This is a cadaveric section, so you cannot see the cuff. The muscle is dissected from the bone subperiostally. And the beauty of the surgery you can look at, you cannot see any residual stuff on the bone. Leaving a residual on the bone, it's not going to be a big deal, but it's not going to look nice. So neurosurgery is a delicate field, and I'm sure you will all agree. So we retract temporalis muscle as low as we can go because we want access to the posterior root of zygomatic arch. Let's move there. This is a discussion of craniotomy where the burr holes are. I'm going to show you the image so that this does not look heavy. Summarizing it, point A is around the posterior root of zygomatic arch. The point B is at McCarty keyhole. And in older patients, we use the point C as well because in them, bone might be adherent to the dura sometimes. Give me a minute. So these are the points A, B, and C that I was talking about. You can vary the points according to your lesion location. This is the root of the zygoma. So you can start your first burr here. The other burr goes around the McCarty, the depression that you feel right at the frontal bone. And in aged patients, or if you do not have a craniotome, then you can make another burr here at the superior temporal line. This burr is going to help you dissect it because around this coronal suture region, in this region, if you can see, there's a suture here, and then there's a suture here. Along the coronal suture region, the dura is usually very tightly adherent. So this burr helps if you do not have a craniotome. We clear this. Are we all on the same page?
Yes.
Yes.
Okay, let's proceed. This is another variation of craniotomy. Now, there is another thing as well, which is often asked in the exams, in the rounds. How big your craniotomy should be, how posterior should you go, that will depend on lesion to lesion. There is no one size fits it all. You will, if you're in a very good setup, you will use neuronavigation to accurately mark your craniotomy. If you are not in a setup where you have, neuronavigation, then yes, Dr. Fatma, the range is 3 to 5 centimeters. So it will depend on lesion to lesion. There is another variation which we will discuss in another session, which is mini pterional craniotomy, which is like this small. It's this small, sometimes even smaller than this. So we have to take the craniotomy, and this portion that you see here that I've marked in the green, this region, you cannot use your drill, or if you're using the guide wire, you cannot use the guide wire here. You can only ronger this or use a thick burr hole to a thick burr to ronger this away so that the bone can be fractured afterwards. So once the flap is removed, we come back to my favorite portion. I think you have all figured this out by this point. We ronger the sphenoid ridge completely till the floor of middle fossa is flush with anterior fossa, till we reach the superior orbital fissure. Why? Because we need access to both portions. And once we remove this clip, we have straightforward access to cavernous sinus and proximal segments of MCA. It also gives access to optical carotid and carotid oculomotor windows. I think there's a doubling of the slide. And it also facilitates clinoidectomy if you need to. If you need to remove ACPs, then you will have to take the lesser wing of the sphenoid. So this is not a pterional craniotomy, by the way. It was a decompressive craniotomy that I did quite a while back, but I included this image because I wanted to show you how much we have ruptured the bone here, even though this was for trauma. Let me mark it. You can see that this is floor of the middle cranial fossa. This is floor of the anterior cranial fossa, and this lesser wing of the sphenoid should have gone like this, which has been ruptured away. And it has been ruptured so much that it's now this smooth slide. And you can see the anterior clinoidal processes here beautifully. So if you look at the other image, you can see the paired ACPs here. If I wanted to, I could have gone even further down, removed the anterior clinoidal process, even though I did not need to because this was for trauma. But even in trauma patients, this works beautifully. And you can see that from this side, let me change the color. From this side, you are standing here from a lateral point of view, but you can see the middle cranial fossa floor perfectly well because it's flush. It's completely flush. There is no ridge of bone that is, obstructing the view. We are going to have a separate session on the decompressive craniectomy and craniotomy. Let's not go in the details, but I wanted to show you what it meant if you took the sphenoid wing completely away. So let's move. This is the actual craniotomy that is usually done in the pterional approach. Once we have removed the bone, you can see it shows the frontal portion, the temporal portion, the dura is visible, even a small indentation here is visible, just superior to the middle meningeal artery, which is demarcating us that sylvian fissure is going to be right here. And they have not taken away the ridge yet. So you can see this triangular portion here as well. If you are doing a meningioma surgery, especially sphenoid wing meningioma, you are going to coagulate this middle meningeal artery right here and before you even proceed. So once we do that, then we slightly retract. Let me see. We retract the lobes. Once the extradural retraction is done, then we go back and do all the extradural bone work that needs to be done that we have discussed in sphenoid wing meningioma sessions. This is an illustration, and since this is an illustration, obviously it is going to show exaggerated structures. You can see the indentation of sylvian fissure here. You can also see the lesser wing of a sphenoid. This is the frontal dura. This is the temporal dura. The dural flap is going to be curvilinear. It is going to be based on this portion, on the sphenoid wing, and you will retract it inferiorly towards this side. Before doing that, obviously, we do put up the tuck-ups, and we ensure that the tuck-ups are intact while we are closing. Let's move on. So this is the intradural exposure. Once we have, taken the dura away, we have flipped it, and let me see here. You can see the frontal operculum. You can see only a small portion of the temporal operculum because probably this person who dissected did not want a lot of exposure for the temporal lobe. If we wanted exposure, we would have ruptured this portion away completely and cleared the temporal opercular region. You can see MCA. These are the terminal branches. Along with MCA, you will also see the superficial sylvian vessels here as well. the anatomy remains consistent. We have done it countless amounts of time. Anybody who has not listened to the previous sessions, I'll leave the links on the group again. Closure is easy, straightforward, no big deal. The primary goal is a watertight dura. We close it with non-absorbable sutures. If there was any problem with the dura, if it was a meningioma and you did not want to put the dura back, you have the option of pericranium. A part of the reason I take the pericranium in the beginning is because I am planning a graft. The other option is fascia lata if you don't want to take pericranium, or for example, if pericranium is compromised in cases of osteomyelitis, or if there is any other problem going on, you can take fascia lata, you can take a synthetic substitute, Duragen, etc. Always ensure that your tech sutures are intact while you're closing. And because sometimes what ends up happening is the sutures are relatively compromised. They are intact but compromised. Once you put the bone back, the pressure from the bone flap is going to make these sutures looser. Patient might have a postoperative small epidural bleed. We replace the bone flap with the help of titanium plates and screws, whatever is available at your institute. There are, excuse me, there are burr hole covers, etc. Burr holes can be filled with the bone dust or bone cement. We usually save the bone dust while we are taking the bone flap away, so we have never used bone cement for these. Move. And yes, temporalis muscle reconstruction is really important. It's not going to be a neurosurgical problem per se if you don't take care of this, but it will end up in having a better cosmetic outcome. It will also prevent temporal wasting. Patient's jaw function will not be as compromised. So for myofascial repair, we have discussed it. The cuff that we left in the beginning, we reattach the muscle to it, and we suture it directly. And the muscle repositioning should always be without tension. Because if you're going to do it under tension, then the muscle is going to go in post-operative contraction and fibrosis. So we close the gallia and the skin, and we can place the subgaleal drain, etc. For 24 hours. That is a surgeon's choice. It depends on case to case. That's it for today. We are running late.
Madam, I have a question.
Okay.
Ma'am, as you shown in your decompressive craniotomy, that you place the drain against the gravity. Usually in our ward, what our consultant tells us that we should place the drain with the gravity, because in the first 24 hours we make vacuum in the drain, but after 24 hours we remove the vacuum and leave it as a passive drain. So what are your thoughts about that?
So you, where do you place the drain exactly while doing the DC?
Ma'am, we place it with the gravity, just like it's at the base of our flap.
I am not sure exactly what you mean. So you place it subgaleally, or where do you place it?
Subgaleally, ma'am.
Okay. Yes, so that technique would depend
Can you
from
please
surgeon to
show
surgeon.
us
It's a surgeon's choice.
Ma'am, can you please show us the CT of your decompressive?
Okay. Give me a minute. Let's go back. Yes.
Now, here you can see that you have placed it up at the top of
Yes,
the head,
I
right?
have placed it. Yes, yes.
So
So
we
you
do
place it
at the
somewhere
beginning.
here?
Yes.
Okay. Yes, that's also perfectly all right. It's just that the patient complains a lot more with this. But it's a surgeon's choice. Yes, I get what you're trying to say. I think it would be a very good option if you place it like this, because all the collection is going to come like this, and it would be probably easier to drain.
Yes,
I
ma'am.
get what you're trying to say.
So, okay, so thank you so much. I was just asking why have you placed it over
No,
the
that's okay.
with the
That's
gap?
okay.
Thank you,
If you can see in the other image, the drain is quite long. It's going to the inferior portion. It's going till here. So there's this entire curved thing, because a lot of times the patients are lying supine, so gravity is not working in the way it's supposed to be. The collection will come here, I see your point. The collection will come here. If a patient is, in a more gravity-oriented position, like if it is in a very head-up or sitting position, etc., then the collection will be a lot more. If a patient is lying down on the ICU bed, and if the head elevation is only around 30 to 35 degrees, which is what we usually do, then this probably could work, could not work. I think it will be case to case.
Okay,
But
ma'am.
it's
And
a good observation.
thank you so much, ma'am, for clarification of this point. Can I ask another question if you don't mind?
Okay.
Yes. So, ma'am, now we say that the zygoma is the highest point, and we actually determine our angle, like let's say 45 or 30 degrees, depends on the structure we are trying to reach. So, how do we calculate the degrees? Is it just eyeballing it, or we can use some kind of tool so that that we can say that okay, now the head is turned now or tilted 30 degrees, 40 degrees. So, please clarify that as well.
Frankly, I'm not sure which institute you are from. We have never used Mayfield. We do not have Mayfield. Part of the reason I included it in the image because it was something that got asked in the exam, and I was not sure because it's something that we did not have in our institute. So we eyeball it.
Ma'am, I
Like for meningiomas, for trauma surgeries, we eyeball it. I'm not sure about the institutes that they have it. There will be a way to calculate the exact degrees because there are exact degrees mentioned.
Ma'am, I'm from Khyber Teaching Hospital in Peshawar, and we do have Mayfield. We have used it
Okay.
once or twice, but our consultant was not comfortable with it. So now we don't use it. We just only use it for stereotactic surgeries.
Oh, okay. But if you have it, then you are in a very good position to learn about it. And it's okay if somebody who is in a later stage of their career, if they are not open to it, it's completely okay. The benefit that we have is we are still in the learning stage, right? We are still modifiable, we are teachable. So if you have something in your institute which is available to you, make the best use of it, learn it, use it so that you get this edge which other people do not have. Does anyone have any other question? Am I audible?
Thank you so much, ma'am, for the help for the answering the questions.
Thank you. Okay, so we don't have any other questions. If you come to think of any other question later on, you can always put them on the WhatsApp group. I usually make sure to answer them. Thank you so much, everyone. This is a wrap for today's session. Thank you. Have a good day.